morning. For those of you who don't know me, for the 6 of you that don't know me, I'm Hilary Loge. I graduated from this program 2 years ago in 2015 with the last name of Galogli, and stood before you almost exactly 2 years ago giving my Chief Resident Grand Rounds. A lot has happened to me in the past 2 years, and I'm here today to share with you a little bit of my experience. As with my first Grand Rounds, I struggled to find a title for this talk that would encompass the subject, be catchy, not give too much away. And this is what I settled on. However, I had a very close runner-up, courtesy of Dr. Wiedemann. Thank you for the title suggestion, sir. Always helping to break it down and get real. Of course, this notion needs a little asterisk for those of us in the military who are so poor that we are, struggling to heat the house and feed the children. So the first disclosure that I have before I start is that while I do have a few concrete facts scattered about the talk, I'm largely giving you my impressions and conclusions based on my experience and that of my close friends. So this lecture is the definition of subjective. Secondly, as the title suggests, I'm new. I've been in practice for 18 months. So all the wide-sweeping, generalized, whole-world comments that I make need to be put in the context that I am, in fact, new, and that my N is still very small, that I lack certain perspective. Lastly, as most of you probably know, I'm practically allergic to talking about my feelings. I know it's the PC thing to do nowadays, but it's always been one of my least favorite things. You can ask my husband. I know as surgeons, many of you may feel similarly, but in preparing today, I realized that we're all just going to have to suck it up and delve down into a little bit of emotion, just a little. And no disclosures relevant to the military, except that I had to wear my uniform. Okay, so today my main objective is to open the door a little bit and give everyone a look into this period of time in a surgeon's career that we don't spend a whole lot of time talking about during training. What has surprised me the most about the last 18 months is how surprised I have been about the intricacies of transitioning from training to practice. How hard it is, how exciting, how scary, how unexpected, how unprepared I was for the degree of change. I'm going to spend the first part of the time talking about how chief residents perceive themselves and how they are perceived. There's actually some real numbers out there that quantify how great or not great we think we are. And I'll tell you a little bit then about my path, the road that I've taken between residency and practice. And at the end, I would like to have an honest discussion about how you as residents can prepare yourself clinically, logistically, emotionally, so that you have an easier transition than I did. And finally, how can we, the staff, both senior attendings and junior, help both graduating residents and perhaps the other new attendings entering practice? Some of you may be thinking, why are we talking about this again? We talk about this all the time. Drs. Wiedemann and Humphreys have both given excellent grand rounds this academic year that discussing different nuances of this subject. Graduating residents aren't ready. There are these transition to practice mini fellowships. I'd like to approach all of this through a slightly different lens. One of a new attending, me, now recently graduated from this program, trained by you, who is now teaching our residents. So I'm hoping that potentially the lessons that I've learned in my full circle can help identify areas that we can all improve. Let me quickly give you a little bit of background about me so you can understand a little bit where I'm coming from. I entered Boston University Medical School in 2005 at the ripe old age of 25. I had a 4-year gap between college and medical school. I chose to take a scholarship from the military, from the Air Force, to attend medical school for a variety of reasons. It's a very long story that I told during my chief year grand rounds, so we won't go there today. When I started my clinical rotations at the beginning of my 3rd year of medical school, the one thing that I knew for sure was that I definitely did not want to be a surgeon. Fast forward to the end of 3rd year, and I realized that surgery was the only life for me. I'm sure some of you experienced the same thing. I entered into the Air Force match in December of my 4th year. The match works very differently in the Air Force, and suffice it to say that I put David Grant Medical Center at Travis Air Force Base as my #1 choice, and I ended up matching. And I didn't quite understand how coveted the spot here is, the active duty Air Force spot, until I got here and was a resident. I trained here as a general surgery resident from 2009 to 2015, belonging to Travis Air Force Base, but functionally acting as a UC Davis civilian resident. The main difference between me and the civilian resident seemed to me that I had to do push-ups intermittently, endless military computer training, Dr. Height, and I had to drive an hour to pee into a cup more often than seemed fair. I decided not to pursue fellowship training and to enter practice as a general surgeon. And it turns out in the military, the end of residency can be very, very stressful as you do this kind of dance with your specialty consultant where they try and figure out where your first duty station is going to be. And I had a lot of help from a lot of people, some of them in this room, and I was ultimately notified that I would get to stay here at Travis with my family. I started practice in August of 2015. I took the written boards, took the oral boards, and tried to settle in. I quickly realized that if I was going to deploy down the road, that maintaining my trauma skills would be very important, and the only trauma patients that we saw at the Air Force Base were by accident. So I started moonlighting in November of 2015 at Kaiser South Sacramento, taking trauma and critical care call a few days a month. I continued my practice at David Grant until the spring of last year, when a unique opportunity was presented to me. The military is pushing to expand its military-civilian partnerships with the aim of increasing or maintaining currency for surgeons in particular. And I was asked if I wanted to join the surgery group at the VA Mather, and I leapt at the chance. I moved my entire practice up to Sacramento, and I've been there ever since. Because working at 3 hospitals wasn't enough, when the powers that be suggested that I form yet another military-civilian partnership, I finally got my coveted green badge here at UC Davis, and I'm taking ACS service call every few months. So this is me. I work a varying amount at 4 area hospitals. If anyone needs advice about getting credentialed, see me after. I'm really, really good at it. I was asked recently to pick a favorite hospital, Dr. Wiedemann, obviously, the VA, obviously. So there's a couple things I want to add before I move forward, and I'll call them my disclosures part 2. Despite the occasional outward appearance of being grumpy, I want everyone to know before I go on that I am glad that I chose surgery, okay? I'm not here today to try and warn anyone off or be negative. Surgery is the greatest specialty there is, period, okay? In particular, I'm so very glad that I trained here. I don't think you get better training anywhere else, and I know for sure that you won't find better people anywhere else. So, with this firmly in mind, let's move on. Let's start at the beginning of the end, or the end of the beginning, depending on how you choose to think about it, the chief year of residency. Perhaps a fair assessment of the worldview as a chief resident is that it changes dramatically between the beginning of the year and the end of the year. You start out just bursting with this enthusiasm that comes with being the boss. Your confidence peaks. You run rounds, you run your team, you choose your favorite cases, you talk directly to the attendings, you have Dr. Bold's cell phone number. Then, and the timing varies, but sometime in the middle of the year, reality sets in, starts to tickle the edges of your mind, and it dawns on you that this might be the last. The last hernia, the last gallbladder, the last hernia, the last gallbladder, the last colon that you do while you're in training. And that, oh, by the way, the next one, you're going to be completely on your own. This doubt and anxiety kind of simmers in the back of your mind. You push it aside because there's a euphoria as you get to the end of your chief year. There's the knowledge that the Q2 call is soon ending and that you'll be free if you're not doing fellowship, of course. On the very last day of residency, you walk into the house staff office and you hand over your badge and your pager, two things that have been physical extensions of your body for the last 5 to 7 years. And then you walk out. Nobody says congratulations. Nobody cheers. The lights don't flicker. Confetti does not rain down from the ceiling. It is ridiculously anticlimactic. Fair warning. The next day you wake up and you don't really know what to do. I mean, for me, I was planning a wedding, moving to Davis, remodeling our house, so I had plenty to do, but you get the picture. It's super, super weird to finish residency. And one of the questions I had when I was preparing for today is, as graduating chief residents, how do we see ourselves? And how do our new future colleagues see us? And it turns out that this has been a really hot topic of discussion over the past few years. As discussed in those prior grand rounds, the excellent grand rounds, Dr. Weedham and Dr. Humphreys, there's been this increasing awareness in surgical education of a growing problem with trainees. The concern that with limited work hours, lessened autonomy, less invasive management of surgical patients, that at the end of 5 to 7 years of training, we are not ready. That perhaps the majority of us are not ready to be independent surgeons. It's so depressing, so depressing. This ABS newsletter in 2014 focused on these issues, although really the literature on this subject has kind of been accumulating for the last 8 to 10 years and trying to figure out how to address these issues. So what do they think we should do? Well, the first idea that the ABS had was that we would use this thing called the SCORE curriculum, which standardizes the expectations of what residents should be learning in residency. If you look at the list of the SCORE curriculum's expectations of what cases that you should, what operations that you should be comfortable with at the end of residency, it's like 10 pages long. It includes things like Nissens and paraesophageal hernia repairs and LARs and APRs. I don't know how realistic that is. Other ideas included allowing residents to customize the last 12 months of their training based on their interest, whether it be general surgery or subspecialization. And lastly, as Dr. Wiedemann educated us about in November, there's this push towards new surgeons doing a transition to practice fellowship, where you spend a year with senior mentors, and the mentees over the course of that year are supposed to develop more and more autonomy, and on the last day of that year, they are ready. But isn't that what residency is supposed to be? I want everyone, no matter where you are in your surgical life, just take a second. Take a second and think about whether you think you are ready as a resident, or if you think you weren't ready on the day that you finished residency. My guess is that the answer will vary quite a bit, depending on what decade that you trained in. And what exactly does ready mean? How does the ABS or residency directors or anyone quantify what ready is? Well, someone started off by just asking them. So I've got really, really good news. They sent out this survey, the ACS did. They sent it to 3,000 young surgeons. 282 completed the survey, sounds about right. And 94% of us thought we received adequate surgical training and were prepared for the transition. 94%, we're good, no worries. Well, as it turned out, when they asked senior surgeons whether they thought their junior colleagues were ready, only 60% said yes. Womp womp. The news gets worse, unfortunately. A survey of fellowship directors in 2013, published in the Annals of Surgery, was even more dismal. Among the scary results were that fellowship directors felt like 2/3 of new fellows were unable to operate for 30 minutes unsupervised. 2/3. 40% of them demonstrated lack of patient ownership, and, wait for it, 1/3 of us were not competent to do a laparoscopic cholecystectomy by ourselves. 1/3. For real? These studies left me with very raised eyebrows. So I took a minute to think about how I felt about my own preparedness at the end of residency. How did I feel on June 30th, 2015? I think that the best way to say it was that I felt, my brain knew that I was well trained. I told myself to be confident, but I also remember being filled with doubt and angst at the idea of really being on my own. Weirdly, I found studying for the written and the oral boards was really helpful for my early confidence. I felt like the big refresher helped to reaffirm that I did somewhere in my brain have the necessary knowledge. The trouble then comes, of course, when you try and apply that knowledge to the rainbow of patients that we see in the world. So after getting credentialed, again, come talk to me after, really good at it, I was ready to go, maybe. I found that the first days in practice are punctuated with some really big moments and then a lot of smaller moments. You decide on the schedule, you're allocated OR time, someone asks you to make preference cards. What? Preferences? I had no idea. I literally just told them to copy my colleagues. Shockingly, your OR days are not automatically filled with cases, as they were in residency. You actually have to see clinic. And lo and behold, you are the one who's deciding which patients get an operation and which ones don't. Eventually, the day of your first case arrives. There's a huge amount of anticipation, nerves, what ifs, self-doubt. You read every textbook that you have over and over. You Google anatomy images. You watch YouTube. By the way, my first case happened to be a shoulder lipoma. But man, oh man, I was prepared for that shoulder lipoma. Being in the OR for the first time as an attending is like an out-of-body experience. There's this voice in your head that's screaming, isn't there somebody here that's supposed to be in charge? They want to know how you want the patient positioned. They want to know what sutures you want. They want to know what instruments you want. Apparently, this is what preference cards are for. Someone asked me what mesh did I want for an inguinal hernia repair, and the one that Dr. Ho uses was not an acceptable answer. So, like I said, it's an out-of-body experience. It's very, very overwhelming in the beginning. On top of all the newness and the enormity of this change, there was an extra challenge presented to me as a new attending. I started teaching residents on day one. Please understand, I love our residents. I love you guys. I really do. And I find teaching to be very rewarding. But in addition now to being wholly responsible for my patients, I was now responsible for your actions and your education. And so it just turned out to be a lot. One thing that you realize right away in the OR is that you have no idea how to expose. None. For yourself or for a resident. You just spent 6 years of your life with somebody else making you look good in the operating room. I felt like an intern again, honestly. I was fumbling with retractors and instruments. It was very, very humbling. And lastly, I really like to operate, as I'm sure many of you do. I like to actually be the one operating with my hands. And as a new attending teaching residents, it's very difficult to find the balance of wanting to do it with myself and then making sure that they're getting the appropriate opportunities. I know this struggle continues. You know who you are, attendings for a lot of us. It's just really, really fun to operate, right? And it's hard to share. So eventually the shock wears off and you settle into being in charge. For me, the novelty was almost immediately replaced by this growing, total body, mind-numbing fear. It's really difficult to describe. So some of the new attendings, met with the residents a couple weeks ago and talked about these issues. And Ian Brown, one of our trauma and critical care doctors, really summarized this feeling better than anything I've seen or read. So there's this emotional aspect to surgery that you simply can't experience until you're the one who's ultimately responsible for what happens in that room. And it's very, very different type of weight on your shoulders. These huge realizations happen upon you in the beginning. You are responsible. That word has never meant so much to me in my entire life. Your patients are yours forever. There is no such thing as rotating off service. For me, the beginning of my practice was permeated by the fear. Fear all the time. A day of elective hernias, which at one point in residency was so relaxing and fun, was all of a sudden a death trap. I mean, somebody was going to die. I would stay up all night on call, picturing all the horrible scenarios that could roll into the emergency room. I would stay awake staring at the ceiling, mentally walking through all the steps of what I would do in these innumerable, terrible hypothetical situations. And then I started not sleeping well on my non-call nights. I was so tired all the time, and we're used to being tired, right? But this was a very different kind of fatigue, and it wasn't because I was being paged all night. It was because my mind was attacking itself. You guys know me. I would never in my life describe myself as an anxious person. I actually would describe myself as a fairly confident person. But at the end of 2015, I was frankly a mess. I mean, I was close to panic attacks, unhappy. It was very paralyzing. I don't say these things to scare anyone, and it's not easy to stand up here in front of a room full of my colleagues and say this stuff out loud. But I want you to understand that this is normal, or at least it's on the spectrum of normal. Nobody wants to talk about it. Nobody warned me. And for a long time, I felt like there was something wrong with me and that I was in the wrong profession. I started Googling being a chef and being a kitchen designer. Maybe I'm in the wrong place. And it took me a really long time and a lot of help from a lot of people to start moving forward and to realize that it would get better and that it does get better. Okay, that's way too much about feelings. I'm going to switch quickly now into the positives because there are positives. It turns out that there are some pretty fabulous things about being done with surgery training. Let's start with your weekly schedule. You can work with your partners to set your clinic schedule and OR schedule. I prefer to see clinic patients in the morning because I run out of steam and patience by the afternoon and I get grumpy and hungry. So I see multiple morning clinics a week. OR time, of course, is a little bit more tricky. In the beginning, you probably end up with the OR time that your partners don't want, Friday afternoons. But that's okay. That'll get better in the future. And vacations. Did you guys know, and by you I mean the residents, did you guys know that in real life, you do not have to plan your yearly vacation in a 4-week block? You can take several shorter vacations throughout the year. It's crazy. Okay. Also, you can take a single day off. Like, there's a wedding, you can take a Friday off for long weekends. For those of you that are in residency or just finished, you will understand how this concept completely blew my mind. It was like Christmas. Hobbies. Okay, so I can honestly say that during med school and residency, I had heard of these things called hobbies, but I really had no concept of what the word means. I mean, everybody likes to do things, fun things, on their 4 days off a month, right? But calling them hobbies just seemed a little bit wrong. I found out very quickly that when you go from working an average of 80 hours a week down to 40 or 50, that life opens up. And if you're someone like me who's used to being busy, that empty time feels like this huge void that needs to be filled immediately. So kind of on purpose and kind of on accident, my hobbies started coming. I already mentioned that within a month after residency, we had our wedding and we completed our house remodel. It turns out I love remodeling. Love it. If you guys want a new kitchen, I will come and be your consultant. We adopted our dog, Abby, 3 weeks after I graduated, and she brought us immediate and immense joy. I highly recommend it. I was told that everybody in Davis has chickens. So, of course, we had to get chickens. My husband and I are pathologic overachievers, and we got this prefab chicken coop, and we painted it. And we got some chickens. These are real chickens. They're real. And we now know a lot about chickens. We'll call that a hobby. In the fall, we adopted our cat. She was living on the hay bales at Travis Air Force Base. She thinks she's a puma, clearly. The following spring, we decided that we wanted more chickens. So my husband, my dad, and I, with our bare hands and some power tools that the surgeon wasn't allowed to use, we built the Taj Mahal of chicken coops. There we go. And our coop was then featured in the annual Tour de Cluck in Davis. Yes, that's a real thing. It's actually pretty fun. You should try it. So for us, our chickens came first, and then our eggs. I have rediscovered my love for cooking. Potentially, there's a picture coming. Potentially. There we go. And I've started making absolutely everything. Pasta, bread, jam, should come for dinner at our house. Pretty good. I shocked my mother and developed a green thumb, and we now have an herb and a vegetable garden. And if that wasn't enough, my family started volunteering with the local club for guide dogs for the blind. And shortly thereafter, we decided to raise a puppy of our own. Tamara joined our family in October at 8 weeks old, and she got really big really fast. She comes to clinic with me on Fridays at the VA and the occasional grand rounds, and she's been a morale booster for absolutely everyone. So you see, hobbies, they're pretty great. And all of this is at the end of the tunnel, I promise. So professionally, things started really turning around for me last spring. As I mentioned, I was offered the opportunity to transition my practice from David Grant up to the Sacramento VA, and I jumped at the chance. And it really has been night and day. I don't mean to disparage anyone at the Air Force Base. They're great people, they're doing the best for their patients, and I'm very grateful for all the help they gave me in the beginning. It wasn't the perfect place for me to start. I've tried to figure out what has made such a huge difference for me, this move to the VA. And first and foremost has been case volume. When I was at the base, I was getting assigned 1 OR day a month, plus a couple of add-ons. Now, since moving to the VA and now at UC Davis, my OR numbers have way more than doubled, and I'm usually in the OR multiple days a week. Repetition and volume, I think, are the key for developing early confidence. Pathology. We all joke about VA hernias and gallbladders, but for real, they're ridiculous. My very first day at the VA, Dr. Wiedemann pulled me into his OR to help with an inguinal hernia that touched the guy's knees. We suctioned 7 liters of ascites out of his hernia sac. I've done open gallbladders for the first time since I was a third-year resident, and I can say that after 10 months of operating there, I feel so much more able to handle whatever walks in the door. Partners. One of the best days for me at the VA was when Dr. Nalani Grace walked in the door to join our practice. It's so very helpful to have partners who are at the similar stage in their training in their life. We can commiserate, we can ask each other dumb questions, we can close our office door and scream at the ceiling if we need to, and we do. It's just really good for your soul, I think. And finally, senior partners. I'm going to skip ahead to the next slide to illustrate. So these are the 3 surgeons that I've worked with most closely at the VA. You all know them very well. They're good, they're kind, they're available, and most of all, they're experienced. So between the 3 of them, they have almost 100 years of surgical experience. When one of this crew tells me that, oh, I've never seen that before, you can officially be impressed, right? All of them, including my other partners at the VA, will drop anything and come to the OR if I need help. It is priceless. Just to draw a small comparison, we 3 are the 3 kids at the VA, the junior attendings, a whopping 5.5 years of experience, and I got to use a significant decimal place. We take selfies, obviously. We eat at the food trucks. We keep it young. We keep it real, which I found to be equally awesome. So going back to the beginning of the talk to ask you all again, why does any of this matter? Well, for some of you, you will soon be transitioning crossing the big line and making this transition, and this is markedly relevant for you. For the rest of you in the audience, this transition is either years away or it's way in the past. But I think that we can all make changes in how we do things that will create more prepared residents and better care for our patients and for theirs. I tried to think of things that I wish I had done better or been more aware of in the final years of residency. I feel like for sure some of this stuff was mentioned to me along the way, but it really gets diluted by the day-to-day survival that is residency. I've put together a list. It's by no means complete, and I'm really hoping that some of you will help add to it at the end. So residents, this part's for you. Starting with the small stuff, to try and avoid my awkward first days in the OR, asking for Dr. Ho's mesh. Pay attention. What sutures are used and why? Which needles are used, when and why? Which ones do you like? When you're doing hernia repairs, pay attention to the names of the mesh and figure out the differences between them. Same with ports, staplers, and so on. Second, get better at exposure. Stand on the other side of the table and expose for your attending. Or have them cross their arms and step back from the table, because that's what it takes sometimes, and watch you, by yourself, get from the skin to the inguinal canal around the cord in a hernia repair. I learned quickly that it's a lot harder than it looks. When you're in your final year, go back to the basics. Do inguinal hernias again. Do gallbladders. Do anal rectal cases. I'm not saying to ignore the big stuff, but you don't want it to have been 2 years since your last inguinal hernia. Now we start getting into the harder stuff. I want you to ask to do more. Ask for more autonomy. Ask to do the gallbladder two-handed. Ask to take the junior through the case. On the wards, ask to make the plans and ask to manage the patients unless the attending feels like you're being unsafe. However, and this is a really big however, do not do any of this without being prepared. Read about the patients, read about the operations, know the anatomy, have a plan, and most importantly, be able to answer the question, why do you want to do it that way? Every time you demonstrate to an attending that you're an active learner, that you feel responsible for the patients, and that you've done your homework, it makes them want to help you more. Also very important, don't be discouraged. Don't be discouraged if they tell you no, and don't be hurt. It happens, and often for very valid reasons. Just keep asking. Moving on to the somewhat bigger stuff, every surgeon has a lot to consider when they're looking for their first job. And I don't mean what specialty do you want to be in, what kind of surgeon do you want to be. Priorities vary. How do you value clinical time versus research, versus teaching, versus family life, versus geographics? You need to spend some quality time in the last few years of your residency or your fellowship doing some soul searching. Ask the honest question of yourself and your family, what is most important to you? In my opinion, from a happiness, satisfaction, and confidence standpoint, the single most important factor has been who I work with. Who are your partners, junior and senior? Will anyone help you on a Monday afternoon at 2 o'clock? How about Saturday morning at 2 a.m.? You can shift your career to different places as you go on, but I think in the beginning, this is the thing that, in my opinion, matters the most. Okay, attendings. Those of us on the other side of the fence or the table. How can we help residents be better prepared to enter practice and be safe, independent, productive, and fulfilled surgeons? I broach this subject with humility and with full recognition of my own inexperience and potential naivety. I've been dismayed by recent discussions in forums like this one, where the comments focus on residents needing more supervision. For example, recently we had a third-year ER resident who pulled a pigtail catheter on a PICU patient and had a bad outcome. If we truly need to be supervising a resident who is about to graduate doing small procedures, then we're doing something wrong from the get-go, and we didn't teach them right the first time. Bad things happen in medicine, and it isn't always a matter of supervision. A knee-jerk reaction to every complication with, we need more supervision, can be counterproductive. I want you all to start. I want to encourage you all to start saying yes. Or if you're not quite there yet, then think about saying yes. Say yes when residents ask you to do a little bit more, to have a little bit more autonomy. I do not mean say yes whenever, to whomever, in any situation, but you weigh each case and you make a decision and maybe just push yourself a little bit in your comfort zone. Because while your patient in front of you is the top priority, of course, you have to remember that you are affecting all the future patients of that resident that you're teaching. That being said, hold them to a high standard. Expect preparedness. Don't let things slide because it's easier than saying something. If they are asking for more, then you ask for more. Next, if and when residents approach you to ask about your experiences or with concerns about their own, try and take the time to listen. Be honest with them about the challenges that you faced or the obstacles that you've overcome. Talk about when things were a little bit hard for you. I know it's edging a little bit far down the feelings road, I get it, but I think that it does help to know as a resident that the people whom you respect so much didn't have a perfect road getting there. Finally, along the same lines, be a mentor. So many people in this room have so much to teach, and I'm not talking just about surgery. Mentor residents and be mentors to us junior attendings who may feel a little bit lost at times. And as a reminder to those of us who are new, you do not have to be a senior surgeon to be a mentor. I said at the end of my grand rounds as a chief resident that it takes a village to raise a surgeon, and we are all a part of that village, and I think that we can continue to push ourselves to do better. So if you've been paying attention, you will agree that I have a lot of thank yous to hand out. My family, friends, of course, all my partners along the way, Travis, VA, UC Davis. Thank you for all that you have done and continue to do for me. In particular, I would like to thank this guy. Okay, so first of all, he did this. He made this. One day in the OR, I remarked to him that his soothing voice and mannerisms reminded me of Bob Ross. Please tell me that everybody in this audience knows who Bob Ross is, right? Happy little trees. Okay, so this is my Christmas card from Dr. Wiedemann this year. I opened up the envelope, and this is what he did this. Dr. Wiedemann, you've been a very incredible mentor to me, and I appreciate so much about you. Thank you. So with that, thank you for your attention. I'm happy to take any questions, but really I'm interested to hear your thoughts and comments about these issues. And happy Valentine's Day, and this is your official reminder to pay attention to your sweetheart at some point. And that's it.
Hilary, that was great. Awful practical advice and things. We have a few minutes for questions.
Comments?
Well,
Dr.
I'd like to
Wiedemann.
congratulate Dr. Loge for really taking the initiative to seeking these opportunities. This wasn't easy, trying to find all these opportunities to gain experience in practice over the last 2 years. And you can see how diversified her practice is now. And it really, I take pride in seeing her maturation too and gaining confidence. The VA is a pretty protective environment, as you know. We have a lot of senior attendings. We're always around them. We give a lot of advice and maybe a little bit over advice at times. And Dr. Loge implied that she liked this advice at first, but I'm wondering now, are you getting fed up with us? Let us do your thing, call us when we need, and forget about all this daily rounds with all the attendings provided. I would think that would be the case. At some point you say, I want the independence. How are you feeling your status is now?
Yeah, I think it's a very comfortable place to be in when you feel like you can be on your own when you are comfortable, and if you're not, then you can ask for help. So it actually allows you to go further in your comfort zone when you know you've got backup in the next building in their offices. So it's just kind of this like warm security blanket to have people around, and it allows you to be, I think, more independent than if you're by yourself in a hospital in the middle of nowhere, and no matter what you do, you don't have anyone to call. So certainly the degree of help that I've needed over the past year has decreased sharply, along a curve, and probably will continue to do so. But I don't really know any practicing surgeon who doesn't look to others for advice or discussion at times. So I think it's always a good plan to surround yourself with great people.
Two things to echo there. One, I think all of you chief residents thinking about jobs, the VA is an underappreciated gem in the job armamentarium for new people in particular. It's a great place to start an academic career, and that's true of the VA system throughout the country. It really is a great place, and sometimes isn't on the top of people's radar screen. And the second thing, as you've indicated many times, is your partners. Probably the most important thing in looking at a job. I would echo whether it's not location. It's not, you can always get on a plane and take a vacation. It's your partners, the people you're going to work with that you're going to need to call when you need help. So. Dr. Goodnight.
Dr. Loge said this back 3,000 years ago. I love what you said about taking responsibility, realizing it's a young attending. All of a sudden, I'm in. I remember my first complication at UCLA when I was a young attending there, and looking around the room and said, "Who is the attending?" It was Bill Longer, Longer's chief surgeon. Chill, but I felt that impressive about the maybe to illustrate M&M conferences. One aspect of training that's so critical, and to developing good surgeons that you can stand up in front of your colleagues and say, "Yes, I was responsible for this," and learn from them and move on, be able to face that fact. And I'm not sure that very nice to
What else? Somebody else has to think things about this.
Yeah.
No, I said everything. Yes, ma'am.
I think it was a really, really nice presentation. I think it's something to hear. You've actually described going into, if you look for a good protected environment, which I really applaud, because I think there are times when people go into a very private practice type situation, and I don't think it may be as quite as collegial as what we have in an academic environment. And so just something to keep in the back of mind. And I say that only because one of my former residents had gone into a situation, and what she found was a very dog-to-dog world in the private practice.
Again, it's the people, I think, that make the most difference. Any other, Dr.
Since you were giving advice to the residents on how to prepare for that transition, the one thing that I would like to add is that it's never too early to fill up your resume with research. Because if you choose to go into an academic practice, it certainly helps if you have many publications, even if you're the second, third, or fourth author. It's never too early. So building up a comprehensive experience of research will then help you transition into academia much easier and continue doing that. So I think we want to do it early, do it often, and learn.
Thank you.
Bill?
That was very interesting talk, and I just wanted to get a different perspective. Someone who's at the other end of the curve. Is you talked about the concern about lack of confidence as a junior attending. Just want to warn you, this may not be universal, but after talking to other colleagues, I think it's pretty common. Is you have a similar phenomenon that happens at the other end of your career, where you actually felt like you had more confidence when you were early in your career and less as you're late in your career, because all your complications add up over the years and you become more risk averse. So that uncertainty sticks with you, unfortunately. It's not going to go away. In some ways, it's going to be more proud. It's different. It's different. I mean, it's not paralyzing, but it's different. And so just that's part of being a surgeon, I think. So that doesn't necessarily go away.
Yeah. Yes, sir.
So,
Dr. Rock.
I've said this before. I think that one of the differences as you mature as a surgeon is becoming comfortable with being uncomfortable. The other thing, which is harder to do now, but helped me tremendously in my first couple of years, is I had a copy of every operative note from my training. And I cataloged them based on the procedure. So before I went in to do a procedure that I hadn't done by myself before, I read every one of those op notes over and over. So I had in my mind what plan A, B, and C were going to be. And it really helps.
Yes, I think the preparing for a case is something that you don't learn as much as a resident as I think as you suggested, that when you become an attending, that stuff that you do in terms of preparing for a case. And interesting, you're all going to learn, we may even be able to start billing for that kind of work. It's very interesting the way this is all going to change, but that's real work that we do preparing for an operation, depending on what the case is.
Yeah, I think you read and prepare differently for cases as a resident than you do as an attending, because certainly I would show up to cases prepared as a resident and you know what the steps are and you know why you're doing it, but when you're doing it as an attending, you not only obviously need to know those things, but it's what sutures do you want? What order are we going in? What are we preparing in order to go to the next step? So there's this whole another layer of bubble that you have to have within your mind that I don't think I ever practiced in residency or didn't know to practice in residency. So that was surprising to me.
It's a message for we teachers as well.
So to piggyback on your last statement, I think as an attending, you do a lot more preparation on the disaster management. And so you're not only like reviewing the case and the steps and what you expect, but all of a sudden all those complications and risks and how do I get out of that mess, you read a lot more about that and get yourself a lot more prepared for those difficult things, I think, than you do as a resident. I think that's just part of that prep that you're talking about.
Right. Yeah. Like what do I do if we have a massive bleeding during a gallbladder, rather than what are they going to pit me about gallbladder surgery? There's that mentality.
Absolutely.
Sir.
Plan it over.
One of the most interesting things for me as a young attending was the difference in perspective on M&M conferences. As a president, you get up to present, and it's very easy to say, you present it, you fall on your sword, and you discuss it, but you don't feel that sense of ownership. And I found early out, I still have to catch myself doing this, because when you get out as a young attending and you're not presenting the complication often in an academic environment, so you're sitting on the edge of your seat thinking, they can tell the story the way it happened, or the way you want it to happen. You have a tendency to be defensive, and I still have to practice that. It gets in the way you're learning, because you learn more as a young attending. I think you've spoken to that in a roundabout way as a young attending than I ever did, I think, as a resident, about how to manage those things and how to continue to learn from your complications without getting defensive. And did you find the same kind of sense of? I mean, I dreaded them when I put the IBC filter upside down. Like that,
Yeah, I feel like I've been lucky in that I haven't had anything major happen. However, my one umbilical hernia recurrence, like I can tell you the guy's name, I can tell you his birthday, I can tell you what he looks like, I can tell you when I saw him last in clinic. You feel it so much differently, and then rather than thinking of it from this guy and like, oh yeah, this happens, he's fat. So you internalize it, and then yes, I think all of our initial reaction is to try and defend ourselves, when really it's what do I do next time? How do I protect the next patient? And what else can people in this room learn from what happened to me? Sir.
Yeah, you touched on a lot of important themes, and it was very nice talk. I think it's important to recognize that it's like anything, it's a rite of passage. I mean, people have this conception that you leave one day as a resident, and you come back the next day as a faculty, and it's an immediate transition, but like anything, you have to walk before you run. And part of it is just recognizing, and I think at some point during the first couple of years, a light bulb goes off and you're like, I know more about this than anybody else, and I'm prepared to do it. And, you get that confidence that you really are able to take people through things and have the experience and the knowledge to being, in charge.
And Hilary, I want to commit to you, we are going to have confetti.
It's really kind of you walk out and you're like, oh, that's it?
We have a whole new plan. It's going to happen. Thank you.
Thanks, guys.